Morning. It looks like we are live. Welcome to those of you tuning in from wherever you are. It is morning, 9 a.m. on Tuesday, November 18th, here on the eastern seaboard of the United States. So wherever you are, welcome. My name is Tim Morey, and I work with Ethicon, and I am sort of the behind-the-scenes moderator of the Metabolic Applied Research Strategy massive open online course run by Ethicon. And available at ethicon.edx.org. That's ethicon.edx.org. Most of you watching are probably already registered for the course, and that's how you knew about this Hangout. But if you're not registered, we certainly welcome you to go ahead and get registered. But also welcome you to stay with us for the next 45 minutes to an hour while we have a conversation with one of the lead Metabolic Applied Research Strategy, or MARS, investigators and course faculty, Dr. Lee Kaplan. Dr. Kaplan is a paid consultant for Ethicon. He is director of the Obesity, Metabolism, Nutrition Institute at Massachusetts General Hospital and associate professor of medicine at Harvard Medical School. And he is joining us today from the Harvard iLab in Boston, Massachusetts. So welcome, Dr. Kaplan. Good morning. How are you?
Good morning. It's nice to participate, and although I can't see anybody but you, I look forward to talking with everybody else.
Right on. So to that point, we've enabled the question and answer function here in the Google Plus Hangout area. If you're watching on YouTube or if you're watching within the course, you won't have this functionality available to you. But if you go to the Google Plus page, we have enabled the Q&A function, and you can type in a question as we're speaking, and then we can get to it and have Dr. Kaplan weigh in with his response. But let's get going. So far in the course that we're taking, we have been through essentially 2 weeks of content. The first week we established just how complex a system we have in place that regulates our energy balance, and we introduced the notion of a set point. And then in the second week of the course, we debunked our first myth, and that myth was that weight can be reliably controlled through voluntary adjustment of energy through diet and exercise. So, Dr. Kaplan, I asked our course participants to post reflections at the end of each week about what they had learned and what they had taken away. So I guess I'll start with asking you, kind of as the course faculty, as the lead researcher for MARS, for someone who has gone through that first week of content and now has a better understanding of energy balance and of set point, what would you hope that someone would take away from that as far as what they understand, and then how would you, hope to see them apply it in their life, whether they're a surgeon or a primary care physician or a nurse or a dietitian or what have you?
Or a patient, even, potentially.
Or a patient, absolutely, because we do have some patients taking the course as well.
Right. So I think the most important thing is we know that if you don't eat, you're going to lose weight. When you get sick, you lose weight. We know that if you purposely try to overeat, you'll gain weight. But these are very, very transient types of things, and they don't really have much predictive value, meaning that if you try to overeat and gain 50 pounds, let's say, you're going to have a heck of a time doing it because the body reacts. You'll gain 5 pounds pretty easily, maybe you'll gain a little bit more, but then when you really try to gain a lot of weight, your body wants to maintain, it defends in both directions how much fat it wants to have. Fat is the fuel of the body, and the body says, I need a certain amount of fuel. And the amount of fuel is appropriate to the needs of the body, and that's evolved over maybe the million years of human life. Actually, it's evolved a lot longer than that, over several dozen billion years of animal, plant, and bacterial life. So that's what you can do voluntarily. But if you want to change things in the long term, you have to actually change where your body wants to live. And if you want to do that, you've got to figure out how to make those changes in physiology rather than changes in voluntary action. By the same token, what we've learned is obesity is when the body is confused, and we could say disease, but confused disease is the same thing, and it defends the wrong amount of fat. It would be like your car deciding one day that it needed the gas tank of a jet plane, and carries around all this extra gas. And if the gas is not necessary for the car, but the car, if it had the choice, is confused into thinking it needs to carry around a lot more gas. That's what the body is. It's confused into thinking it needs to carry around a lot more fat or a lot more fuel. And dealing with that issue is the challenge of treating obesity. But understanding how you get there is the challenge of preventing obesity.
So this brings me to an interesting comment that I saw in the discussion forum that was posted by Betty Lou, who said, I think weight gain is fairly straightforward, but it's weight loss that seems to be far more complex than I ever imagined. And it sounds like our bodies are designed to store fat and maintain those fat stores. They are not designed to let those fat stores go with a little or even a lot of effort. And then here's where I'd be interested in hearing you weigh in. And she says, if it's not a simple equation of calories in and calories out, I'm left not knowing what any of the answers can be, which sounds to me like, okay, I understand that maybe we struggle to lose weight and we fight the regulatory system. How do I actually change it then? What are the answers? We've established how difficult it is to change the complex system we have in place that regulates our energy balance, but what is the answer for someone who's looking to change it then?
Right. So I think we have to be straightforward with what we know and what we don't know.
Yeah.
This is always a two-part story. The first part is incredibly depressing. If you're going to persist in believing that you can do this by just eating less, you're going to have to find a box to put yourself in where you don't have access to food and lock that box up, because that's the only way to sustain long-term weight loss merely by doing that. So that's the bad news, and that's what the person who you were referring to is reflecting. But the good news is, if we really understand it, then we can understand what causes the body to be confused and defend the higher set point in the first place. And that's really what we're all about. That's the reason we do all this research, because we recognize that the problem of obesity is getting worse and worse and worse, and that the problem of and the solutions for it are elusive at best. Okay, so having said that, the one thing I disagree with the writer or caller is that that the problem is losing the weight and that it's easy to gain the weight. It's actually not easy to gain the weight. What happens is that if you try to gain the weight voluntarily, it won't work. But if you live in our modern society, unfortunately, there are forces in the environment which promote obesity, which promote the brain, which is the unconscious brain or the subconscious brain, to establish or defend the wrong set point, to be confused into thinking it needs to have more fat around. Now, just to go through this issue about how hard it is to lose weight when your body or your brain wants to be at a higher weight. This is normal. It is normal that the body defends its weight, and it's healthy that the body defends its weight. For example, if you get the flu and you lose 10 pounds, you want your body, as soon as you're done with the flu, to get you back to where you started. If you give a pint of blood, you want your body to grow more blood just to the level where you were before, because too much blood is not good for you. It will give you a stroke. And too little blood, of course, gives you anemia and makes you tired and your body doesn't work so well. So you want your body to get you back after you've given a pint of blood, whether you give it voluntarily or you just cut yourself, and bring you to that set point for the amount of blood that you have. Well, in the same way, the body wants the right set point for the amount of fat, because if you get acutely ill and you burn off some of that fat and you lose weight, or you don't eat and you lose weight acutely, you want your body to put you back where it started. Now, if that doesn't work, and sometimes the system does not work when people get into their late 80s, 90s, and 100s, then what happens is you get a cold, you lose 5 pounds, and you never regain it back. And then you get another cold, or something else happens, you get a pneumonia, you lose 15 pounds, and you never regain it back. This system of defending how much fat we have is essential for life, and if it doesn't work, we actually end up on a slow process toward death. That's called the dwindles or failure to thrive. Now, having said that, we come back to obesity, where the body has been fooled by the environment, fooled into thinking it needs to store a lot more fat. We'll get into that, and obviously in the course we get into it in some detail as to why the current environment does that. Once the environment has established or fooled the brain into thinking it needs to defend all that fat. The brain works perfectly normally. It defends that amount of fat. And so it's not that the system is broken, it's that the system is defending the wrong set point. So let me go back and give you an example. If you have a thermostat in your house, and your thermostat is set at 72 degrees, when it's 65 degrees, the boiler is going to come on, the heater is going to come on. When it gets to be 80, the air conditioner is going to come on. If you change that thermostat to 90 degrees, and it's 85 degrees in your house, the heat is going to come on because the thermostat says I need to be warmer. If you go to 100, even with that high thermostat, the air conditioner will still go on because the system is working fine. It's just that the thermostat is set wrong. Obesity, the thermostat is set wrong. It's not broken. It's set wrong. It works perfectly well. It defends the higher fat content. It defends the higher weight. And when you try to go back to what you call a normal weight, what you've decided is a normal weight, your subconscious brain and your body is pushing back. That's the reason why you get hungry when you lose weight. That's the reason why you crave food when you lose weight. It's the reason why your body conserves energy when it loses weight, because it wants to get to that crazy high set point that is obesity.
Can you make a distinction then between someone who is suffering from obesity but is maintaining a stable weight versus someone whose thermostat continues to creep further and further up? In other words, what is driving someone to maintain the state of obesity versus what is driving someone to continually gain weight? You know, what causes someone to gain 10 pounds each year or what have you versus maintaining a stable but unhealthy weight?
Well, so I think that once you incorporate into your thinking that this is about a set point. And by the way, set points are routine throughout the body. There is almost no function in the body that doesn't regulate to a set point. I use the example of how much blood you have, size of your liver, your serum sodium level, your serum potassium level. Time after time after time, we have set points. And they're not fixed in stone, but your body gravitates toward a particular place. The definition of obesity is that there's too much fat in a way that's unhealthy. The definition, by the way, is not BMI over 30. That's just a marker. Just like the definition of infection is something that's infecting you, not a fever over 100.4 or 98.6 or what have you. It turns out that people who are infected often have fevers. Not always, but often. And people who have too much body fat are usually above a BMI of 30, but not always. And in some populations, a BMI of 27 is obesity, and in other populations, a BMI of 32 is obesity. But the bottom line is, obesity is the state of having too much fat. Now, that doesn't tell you anything about whether your set point is stable at too high a level or is growing at too high a level.
Right.
The issue is your set point's too high. Now, it's a subtle difference. Most people with obesity probably don't have a very rapidly increasing set point. I have many patients who weigh over 300 pounds, but when I see them for the first time, they say they've weighed the same amount within 5 or 10 pounds for 10 years or more. They haven't been fighting their set point, they haven't been trying to lose weight, and their body keeps them at the same place. It's way too high, and they usually have cardiac disease, which is why they get referred to us. But the bottom line is that they have a very stable but elevated set point. Now, what happens is if you're constantly trying to fight your set point by just basically starving yourself, even though you might weigh 250 pounds, your body reacts to it and keeps pushing back. And so you may think your set point is going up, but actually you're just artificially trying to reduce your weight below your set point, and given every opportunity, the body's going to push back up. So you think your set point's going up, 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 but actually it's just trying to force you back to that set point. So if your set point's 200 pounds and you've been dieting and working hard to keep your weight at 170 pounds, and you really want to get to 140 pounds, you keep struggling, but your body wants to be at 200 pounds. Until you get to 200 pounds, your body's not satisfied. So it's not that it's trying to go up, it's just trying to get you to 200 pounds. There are some people who, because of continued exposure to this obesogenic environment, over time will see a slow increase or a fast increase in their set point. A good example of that is if you go on certain drugs, you can dramatically increase your set point just by starting a drug. So there are drugs like insulin or corticosteroids like prednisone or certain kinds of psychotropic drugs like Zyprexa and which is olanzapine, or Clozaril, which is clonazepine, I think, but Clozaril is the trade name. Those kinds of drugs very frequently will push up the set point acutely. So let's say you're perfectly normal weight, you weigh 150 pounds, you start one of these drugs, say insulin, and your weight shoots up to 180 pounds. You gain 30 pounds. That's because your set point acutely went up by that period of time. For most people, the rate of increase of a set point is no more than a pound or two a year. But again, if you're 20, 30 pounds below your set point, your body is not trying to gain a pound or two a year. It's trying to get to that set point, and as soon as you let it, it'll go up. It will go up very, very quickly until it gets to wherever the set point is. Does that make sense to you? And do you think that answers the question to the writer?
I think so. Let me ask you this: do your conversations, imagine a patient comes in to see you for the first time. Does your conversation with them differ depending on whether they're at a stable weight versus someone who has been steadily gaining weight?
I think one of the things I say to all people when they come in is number one, I try to define the fact that the body has its own mind, if you will, about how much fat to store, how much energy it needs. And you know, you need energy for a lot of reasons. You need energy for emergencies in case you break a bone or you get sick or something happens. So I start the conversation there, and I always emphasize that obesity is having too much fat, irrespective of how you got there. So if you got there 25 years ago or you got there last week, if you got there because you never lost the weight after a pregnancy, or you got there because you went on a drug, whatever it is, it's the state of having too much fat. We don't usually get too much into the details about how you get there, except to say that we know that everybody has gained weight. All of us are born at a much lower weight than we are now. And so the process of gaining weight, I always emphasize, while scary, is actually less important than the target that the body defends. And so, yes, it may be that somebody gained all their weight and had a higher set point for the last 20 years and then maintained a stable set point, or maybe somebody else sees a slow creep in their set point over a long period of time. The bottom line is today, as of the day that I see them in the office for the first time, their set point's too high, they do have obesity, they have too much body fat, and the solution is always going to be to try to lower that set point back. Now, regardless of how they got there or when they got there, the solution has to be to try to lower that set point. And so we use lifestyle modification to lower set point. We use drugs when we use them to lower set point. When I talk about lifestyle modification, that includes diet to lower set point. Not to restrict what you eat, but to chemically change your diet so that your brain wants to lower the set point. We exercise to lower set point. We get more sleep to lower set point. We try to follow our biorhythms to get a better set point. When we use surgery, surgery is the most powerful tool to lower the set point. But surgery is not fundamentally different from anything else. It just is more dramatic. So there are, on the upside, there are lots of things in our environment that cause our set point to go up. Some people it's sleep deprivation, and some people it's the type of foods we eat, and some people it's the lack of exercise. Whatever it is, there are different people react differently. The most dramatic increases in set point that you'll ever see are due to drugs. But all of these other environmental influences increase set point. Well, on the therapeutic side, all of the things that work over a long period of time lower the set point. Some of them are subtle, like certain dietary changes or exercise. Some are dramatic, like surgery. But the only difference between surgery and lifestyle modification that works for a given patient is the magnitude of the effect. It's like the only difference between sleep deprivation or diet-induced obesity and drug-induced obesity is the magnitude of the effect. They're all working in the same way. The environment is pushing the set point up, and our therapies or our preventative strategies are trying to push the set point back down.
So when you begin trying to lower a patient's set point, be it through lifestyle modification, through pharmacotherapy, through referring them to a surgeon, or what have you, when that process begins, should it feel like a struggle to the patient? Should they be feeling, do they need to work their way through feeling hungry, or should a set point just feel comfortable to a patient, regardless of whether it's being brought downward through intervention?
So this is one of the areas where the new understanding changes our whole approach. Historically, it was often said that if you're not struggling, if you're not working hard, then you're not going to succeed. If all you're doing is trying to resist your body's desire to defend a particular mass of fat or a particular set point, then you're going to be struggling hard, because it'd be like holding your breath. I mean, you can hold your breath for a few seconds or a few dozen seconds, but if you try to hold your breath for more than a couple of minutes, you're going to find your body is pushing back very hard. So dieting, restrictive dieting, lowering calories without changing the content of the diet, is a little bit like holding your breath in slow motion. You can do it for a few months, but it's hard to do it for a few years. So if you lower your set point, your body wants to lose the weight. So for example, after bariatric surgery, which I've already indicated is the most dramatic way to lower set point, what you find is, regardless of what you do, your body wants to lose the weight. It will lose the weight. We often talk about later what happens, and on average, people will regain after any of these therapies some of the lost weight, whether it be on drugs or on lifestyle or on surgery. In the case of surgery, because it's so dramatic, the average weight loss might be 100 pounds, and the average weight gain over the rest of the patient's life is about 25 pounds, about a quarter of the lost weight. That's still a 75-pound loss, if you will. But what happens is, after the surgery, is that the set point goes down, and the body does everything in its power to lose the weight. Just like if you go on a restrictive diet, the body does everything in its power to regain the lost weight. In this case, it's now let's go away from surgery, and let's just talk about things like healthy diets, exercise, better sleep, better attunement to your circadian or biorhythms. When those things work, or when drugs work, what they're doing is they're lowering the set point. And because they are lowering the set point, they lower where the body wants to live, and the body finds a way, and it's actually easy. It may not be easy to comply with a healthy diet. It may not be easy to comply with a regular exercise program, or to comply with stress reduction or getting more sleep. But the goal is to comply with those activities, not try to voluntarily lose the weight, but to actually change your lifestyle in a way that allows your body to want to lower its set point. Once your body is successful at that, once whatever you've done tells the brain that it needs to store less fat, it actually is easy. The weight loss comes off secondarily, and so it comes off easily. So if you're struggling, it means you're fighting your body's desire to store fat. If you make whatever changes in your lifestyle that changes how your brain perceives the set point and wants to lose weight, then the actual weight loss is quite easy. And so this is a completely different message from the message that we've given for the last 50 years, where we've said, I think in error now, if it's a struggle, it's the only way you're going to be successful. I would say that the best predictor of success is if whatever you've done, lifestyle, drugs, or surgery, whatever you've done to treat the obesity, if it's successful, the actual weight loss is quite easy.
That's really interesting. One thing that you haven't hit on, I don't think yet in our conversation today, but which we do talk about a bit in the course, is the role of healthy muscle. And I guess we should distinguish that between calories burned during exercise, but rather signals sent from healthy muscle to the brain that helps with energy regulation. We had a couple questions come in through the discussion forum in the course about this. One from Steve R. Myers, who just says, hey, could you offer a reference for learning more about the effects of healthy muscle mentioned in week 2 on further weight loss? What are the physiologic and biochemical signals that were alluded to? And then Betty Lou had a very similar question of just what does it mean? At what point does muscle become healthy? Is it a matter of obtaining a certain amount of muscle mass? A matter of how often the muscle is used? Can you talk a little bit about that? About the role of healthy muscle, and then also distinguishing between calories burned during exercise versus just having healthy muscle that helps send the right signals.
Yeah, so let me talk a little bit about what we know. Now, this whole idea of healthy muscle and muscle talking to the brain and influencing set point, is new. I mean, within the last 4 or 5 years. Some of the surprises in the scientific literature and in both animal models and in humans is that people who exercise regularly, not crazy exercise, but just a regular modest amount of exercise.
What would you define that as?
You know, somebody who walks vigorously and regularly every day, maybe somebody who walks between 7,500, 10,000 or more steps a day if they're measuring it by a pedometer. Somebody who goes to the gym but doesn't try to become a super athlete, but is just doing regular exercise for 30 minutes a day or 15 minutes a day even. We don't know what the threshold is, and I'm sure the threshold is different for different people. But what we do know is that some of the ways the body reacts to chronic exercise were a little bit surprising. For example, people's food preferences typically changes toward healthier foods. They just want to eat more healthy foods. And historically, we've always said, well, it's because people have sort of gotten on the wagon and they've decided to exercise and they've decided to eat a healthier life. But it's more than that, because we see it in animals too. And those animals don't read any magazines that tell them to become healthy. What they do is that the brain changes with healthy amount of exercise, with healthy muscle. Now, because of that, we've also learned that people actually eat fewer calories voluntarily. They burn more calories while they're resting, not while they're doing exercise, but while they're resting. If you regularly exercise, your body is burning more calories at the non-exercise times. And in fact, if you look, everybody burns the same. If you have a stable weight, you burn the same number of calories that you eat. So if you're eating 2,000 calories a day, you're burning 2,000 calories a day, otherwise you're going to gain or lose weight. And so if you're burning 2,000 calories a day, all those calories you're burning while exercising, 200, 300, 400, is a small minority. So people who exercise regularly and have healthy muscle actually burn more calories during the rest of the day while they're resting, while they're doing their normal activities, while they're sleeping. Now, with those observations, we had to rethink the whole issue of how muscle and how exercise works. And since we have to rethink that, what we now recognize is that there is some kind of a threshold and that there are hormones that muscle makes. One of them is called IL-15 or interleukin-15. Another one is called VEGF or VEGF. One of the new ones is called irisin, I-R-I-S-I-N. You can look in the literature, and I'm sure we can provide references for these things. But this is early days. We know that the muscle talks to the rest of the body. We know that muscle trains fat to increase the burn rate. We know that muscle talks to the brain. But we don't know all the details yet. What we don't know is we don't know which muscle groups. Just like fat around the belly has different implications from fat in the hips. Well, muscle in different places probably have different implications. Some muscle makes more of these hormones than other muscle. Some muscle probably makes the hormones and changes the behavior of the brain and the body more with aerobic exercise. Some muscle may respond more effectively in this regard, in terms of set point, with strength exercise. But we don't know yet. What we know is if you want to reduce your cardiovascular risk, independent of weight, aerobic exercise, cardio type exercise, is important. If you want to increase the strength of your bones, strength exercise is important. And of course, there's value to both, resistance training and to aerobic exercise. But if you want to change the physiology of the muscle such that it sends signals to the brain to lose weight, we actually don't know which is the best exercise yet. And a lot more work needs to be done to understand the subtleties. Because if we understood the subtleties around healthy muscle for weight, healthy muscle for fat mass, then we could prescribe the right kind of exercise in the right muscle group. Is it the arms? Is it the legs? Is it the back? Is it someplace else? We don't know which are the best muscles to do this, and we don't know the best way to train them. However, if you do any kind of exercise, whether you're doing cardio or you're doing resistance training, you're doing it primarily lower extremity or upper extremity or total body, the end result of exercise is that it improves muscle function throughout the body. It's very difficult to isolate individual muscle groups when you're doing whole body exercise. And so any kind of exercise undoubtedly improves the health of your muscle broadly, undoubtedly changes the signals that go to the brain, undoubtedly changes the signals that go to fat to increase burning, and when it works, again, it creates a different physiology. The body wants to lose weight, it lowers the set point, and the actual weight loss doesn't come from the calories burned while exercising. It comes from these global physiological changes, lowering the set point, increasing the calories burned when not exercising. You have to exercise to get the muscle healthy, but it's the calories burned while not exercising that go up the most and that lead to the profound weight loss when it occurs.
Got it. And yet you've also said that that exercise tends to be more associated with weight maintenance once the weight has come off versus primary weight loss. Can you talk a little bit about that?
Yeah, I think that mostly has to do with the speed of weight loss. If you were to be patient and recognize that weight loss that you engender with exercise is going to occur over a year or two, then exercise will cause weight loss. But the problem is most people don't measure weight loss over a year or two. They want to measure weight loss over a few weeks. And so the fastest way to lose weight over a few weeks is to eat less. Now, I've already said that if you just eat less, you eat the same stuff you ate before, you don't change any of your other lifestyle, or you don't have any help from other medical therapies, then you're most of the time doomed to regain. 95 to 98% of people with obesity who lose more than 10% of their weight will regain it over a period of a few years. So the mere just restriction or starving yourself doesn't change set points, it doesn't change the physiology. But if you change your lifestyle in a way that includes a healthier diet and dramatically causes a dramatic lowering of the set point, what you'll find is you don't become as hungry, and because you don't become as hungry, it's the opposite of what happens when you just restrict what you eat. You become hungrier. But if you change what you eat to something that your brain works with better, is less fooled into thinking you need to have obesity, and what the brain will do is will try to lose weight, you'll become less hungry, and you'll lose the weight. That can happen fairly quickly. But if you exercise and you, again, change your brain to the point where it wants to burn more calories, it takes a lot longer. So in practicality, since we measure dramatic weight loss over a course of weeks, exercise isn't that fast. But once you've lost the weight, then if you've been exercising that whole time over 6 months or a year, then you maintain the weight because the exercise has now helped your diet, helped your brain to keep that set point lower. Does that make sense? It's just a slow process. It could work to cause weight loss, but most people don't have the patience to wait a year.
Oh, that's interesting. I didn't know that. It makes total sense. I guess that now is a good time to just make it clear. Although we spent a week debunking the myth that one can affect their weight through voluntary adjustment through diet and exercise, you're not saying that exercise is a bad thing, clearly. It does have benefits. It's just that we should think about it differently than we have in the past, i.e., don't think about how many calories you're burning on that treadmill while standing on the treadmill. Think about the global effect of developing healthier muscle as a result of anaerobic or aerobic exercise. And then dieting, it's not that we shouldn't pay attention to what we're eating. It's just that a restrictive diet is not the way to go. So I think you've made that distinction well during our conversation today, and I think within the course as well. But I think I just want to make sure that we're making that point clearly. And then
if I could add one thing to
sure.
It often gets confused that what we're saying is, as you pointed out, that dieting is bad and exercise is bad. Actually, quite the contrary. Dieting is good and exercising is good. It's how you define it. Exercise needs to be chronic and regular. So you can't just break a sweat, burn 1,000 calories by exercising for 8 hours and expect that that's going to have any long-term impact. But more subtle things, a little bit like orthodonture. You move the teeth slowly over a long period of time. You don't try to move them overnight. And the same thing is with exercise. You want to be doing a little bit of exercise, or as much as you feel comfortable that you can maintain for the rest of your life over a long period of time. Now, with respect to dieting, diets work, but they don't work in the way they're advertised. So almost nobody who prescribes a diet, whether they be a dietitian or a counselor or a physician or anybody, says eat less and eat the same junk you've been eating the whole time. What they say is eat less and eat better. What we're saying and what the research shows is when you're told to eat less and eat better, it's the eating better part that's far more likely to change your set point and cause long-term weight loss. The eating less part actually occurs because of the eating better. So if you merely eat less of whatever it was you were eating before, you won't change your set point. But if you eat better, a healthier diet, whether some people have a healthier diet is more fiber, other people a healthier diet is less antibiotics, other people a healthier diet is less fat, other people a healthier diet is less sugar. People are different. There's no magic bullet here to say that sugar is bad or fat is bad or antibiotics are bad or whatever. What we would say is we want a more wholesome diet. We want a diet that's more natural, meaning it's less processed. We want a diet that's more complex. We want a diet that if you let it sit on the shelf would not survive very long. It would rot. Okay, that type of diet is going to lower the set point, and that is how diet really works when it works well for a long period of time. So a healthy diet is more important than a low-calorie diet. Chronic exercise is more important than high-calorie burning exercise because it's not about the calories that you either eat or you burn on any given day. It's about the balance and how much fat your body wants to have. And if your body wants to have less fat than it has, the easiest thing in the world is for your body to lose that weight because it knows how to do that. If your body wants to have more fat than it has, I don't care how hard you work, wants to have more fat than it has, it will find a way to get there. It really will. And so that's the reason why most people who have been on diets will tell you that the day they gain their first pound back, it's almost always game over because their body is taken over. And so after surgery, that scares a lot of patients because, as I've already said, after surgery you typically gain about a quarter of the weight back over 10 years. And so, but in that case, you're gaining a little bit of the weight or a quarter of the weight back because the set point drops down and goes back up a little bit. But it's not game over because after surgery, in 99% of patients, you only gain back a modest amount of weight. There's 1%, of course, who are the outliers, but in 99% of the time, you gain back a modest amount of weight, but that's only because the set point bounced up a little bit, not because you're doomed to regain all the lost weight. And the reason you're doomed to regain all the lost weight with a calorie-restricted diet is you haven't changed the set point. You've just fought it. It hurts, it's hard, you're hungry, you crave things, you're depressed, you're stressed, and the body says, and you're all those things because the body is forcing you against your voluntary will to regain the lost weight.
It sounds like what you're saying is that if it feels like a battle, it's likely a losing battle.
I agree completely. And there are times when, you know, there are stages along the way. So, for example, it may be a battle to find the time to exercise. That's
Sure.
a battle, that's a battle.
Right.
Once you find the exercise, the weight loss shouldn't be the battle. The behavior that allows your body to change its set point may be a battle because you may not have time to lower your stress. You may not have time to exercise regularly. You may not have time to prepare healthier meals. We understand that. But that's the battle. The battle is actually to change the behavior that allows the physiology to work. The battle should not be around how many calories or how hungry I am, because already that battle is going to be lost. 95% of the time or more, that if you're fighting just on the basis of a calorie counting process, you're going to lose that fight because you're not doing anything to allow your body to settle to a new place, a healthier place.
That's interesting. So it's we had our course participants in the Mars Massive Open Online course. We had them read a short article that was actually in the New York Times last year, and it actually went through the life and times of President Taft, who struggled with obesity, and it looked through it. Actually, they had unearthed some of his diaries where he had sort of taken a rather contemporary approach to weight loss, but wrote to his doctor after losing about 60 pounds that he was continuously hungry. And we asked our course participants, imagine you could go back in time and talk to President Taft and talk to him about his struggles with weight, knowing what you now know about energy balance and weight regulation. What would you say to him? And we had a lot of different people weighing in with a lot of different opinions, some saying, well, it's going to feel like a struggle, but you've got to just kind of work your way through it, and you've got to change your diet even further, or what have you. I mean, of course, you and I don't know President Taft, but I mean, if you were talking with someone who had successfully lost a lot of weight but was still feeling continuously hungry, what would be your first statement to that person or question to that person?
I think it's important to recognize, President Taft lived in a time when having obesity was roundly derided, and that's the first thing you learn in elementary school about President Taft, is that he was heavier than any other president. But I think we didn't know anything about obesity back then. We didn't understand it. We assumed, as many people do today, that it's all about voluntary action. You voluntarily choose to eat too much. But he well described it, which was that he didn't voluntarily become hungry all the time. His body became hungry. His body was driving him to eat. For most people with obesity, their behavior is a reflection of their body's desire to gain weight, not the other way around. It's not that they decided to gain weight or they decided to eat too much and the body reacted that way. So I think what we would say to him is what we would say to any patient today, which is merely eating less, as successful as it is in the short term, as it was for him, losing 60 pounds, doesn't basically change the problem. What it does is it allows you to fight the problem temporarily, just like holding your breath. But in his case, I'll bet there's a whole bunch of stuff we know now that wasn't applied to his care. We know now about sleep deprivation and how that can increase ghrelin levels and decrease leptin levels and cause weight gain. We know that stress, not only the stress you feel, but just the stress of being president of the United States. We know that some people are genetically, was probably genetically predisposed to being heavier than the people around him. And back then we didn't have any of the medications or surgical procedures that we have today, so we wouldn't have had as much opportunity to treat it as we do today. But we could have at least assured him that, number one, the struggle he was feeling was not a problem with his morality or a problem of his lack of willpower. He didn't become president of the United States because he had no willpower or no resources, but really was a reflection of his biology, in part due that he was genetically predisposed, because the environment wasn't as dramatically obesogenic as it is today, but that he also did live in an environment. He lived a lifestyle, maybe because of stress, maybe because of what he chose to eat, maybe because he didn't exercise. But he lived a lifestyle that encouraged his brain to keep his set point as high as possible. Now I go through all that because when you talk to patients that way, one of the first things you see is that they breathe a sigh of relief. It's not all my fault. We're not saying that lifestyle isn't important, and some aspects of lifestyle require a lot of work. Again, finding the time to decrease your stress, finding the time to exercise and eat a healthy diet. These things can be quite hard, but the actual obesity itself, the elevation of the set point, is not primarily the fault of the patient. And when you explain that to them in a way that they understand, what you'll find is you have a partner in the care of obesity rather than an adversary in the care of obesity. And it's moving the patient from an adversarial role, or maybe moving us as physicians and other providers from an adversarial role about obesity to a collaborative role around obesity, the way we try to be for every other disease. Doing that can actually make the patients happy enough that it changes the whole relationship that you have with your patient about all disease, not just obesity.
That is awesome, and something I definitely want to spend more time talking about with you, perhaps in our next hangout, talking about strategies for establishing a collaborative relationship between patient and physician, because I think there's probably a lot of interesting conversation we can have around that and worthwhile as well. You sort of briefly mentioned surgery as something that would likely be offered or potentially be offered to President Taft were he alive today, and actually the article in the New York Times mentioned that as well, that very likely that he would have been offered surgery. I don't want to spend a ton of time talking about surgery in the few minutes we have left, but we are in week 3 of our course. We are now debunking the myth about surgery working primarily through mechanical means. That's a myth that surgery works when it works through restriction and or malabsorption. Very quickly, I guess in the last few minutes that we have together, can you tell our folks who are watching and taking the course, what in a nutshell are you hoping that they would get out of this week as we debunk this myth?
Well, I think that once you recognize that managing how much fat you have is a critical metabolic function of the body, just like managing the sugar in the blood or our cholesterol level. I mean, we're managing fat mass. Fat mass is it's not just weight. It's managing fat mass, and fat is a very important organ for all the reasons we've talked about. So managing it to keep it the right size, to keep the fat itself healthy and allow it to do its job effectively, which it doesn't do effectively if you have obesity. Too much fat leads to all kinds of problems in the fat itself. So doing all that is a metabolic issue. Maintaining a normal set point is a metabolic issue. We have thousands of genes whose products are working to keep us in balance. What surgery is doing, because of reasons that are talked about in the course itself, surgery is doing is it's changing the metabolic physiology in a way that promotes a healthier and a lower fat mass set point. That's what it's doing. Now, how it does that, and what are all the chemicals, and what are all the neurons that are participating, and the hormones, and even the immune system plays a role, that's a subject of a lot of research right now. We only know the very surface of it. We know that, for example, bile acids, which are used to help us, they're detergents that help us dissolve the fats we eat, but they also turn out to be hormones. We know that the microbiota that live in our gut, they have a lot of roles. They're very important to us. One of those roles is they help keep us in balance metabolically, keep our sugar, our fats, and body set point for weight or for fat mass in balance. We know that there are a whole bunch of other hormones that use the same system that marijuana uses, but they're in the gut, not in the brain, that participate in this, and et cetera, et cetera, et cetera. This is so important to keep the balance right, that the body devotes a lot of attention to this whole process. What surgery does is it subtly, it's pretty subtle, changes these signals in a way that drives the body to a lower set point. And then the weight loss isn't subtle, but the signals, the changes in the signals are subtle that lead to profound weight loss. And what that tells us is that getting the obesity to start in the first place, the obesity is not subtle, but the changes in the normal signals that cause the body to gain all that weight, they're pretty subtle. It's not like you see a fundamental change in the body's communication system. What you see is you're using it a little bit differently. That influences the set point, and then you develop obesity. What surgery is doing is it's basically, through mechanisms that we're just beginning to understand, changing that physiology back toward normal. In some people, it goes all the way to normal. They lose all of the excess weight. But in most people, they lose about 2/3 of the excess weight after these operations. The effectiveness of surgery is only more dramatic than the effectiveness of lifestyle or the effectiveness of medications. But it uses some of the same principles of lifestyle change or medications. It just does it in a much more dramatic way. So you can think of surgery as like a drug. Surgery in this case, bariatric surgery, is like a drug. Drug influences physiology. It makes the physiology more normal. If you take a statin drug to lower your cholesterol, it's changing the physiology of cholesterol. What surgery is doing is it's changing the physiology of fat mass. And in so doing, it has this very dramatic and profound visible effect. But the effect inside the body is actually a lot more subtle. And we're working on that.
Now, why is that important for physicians and patients alike to understand? In other words, why can't I just know that it works? Why does it matter how it works to me?
Well, I hate to say this because you asked the question, but it really doesn't matter how it works. What really matters is that it works and is that it's safe. However, because we all grew up, every one of us grew up under the notion that obesity is mostly a bookkeeping problem. It's how many calories you eat minus how many calories you burn or put into your stool. That we need to reverse that thinking. And so it's particularly important if we're thinking about something as invasive, even as though it's effective, as invasive as surgery, that does have side effects, that does have risks, that we understand how it works well enough to understand that it's not merely forcing people to behave in a way that they don't want to behave in. See, for a long time, these surgical procedures, or precursors to them, were developed 50 or 60 years ago. And for a long time, we thought all surgery was doing was forcing people to not eat or not absorb the calories. It turns out that's not true, but that's what that's what we thought. And if surgery worked in that way, we are reinforcing the notion that what surgery is doing is it's getting people to behave in a certain way that they otherwise wouldn't or couldn't do. That's not true. The behavior is a reflection of where the body lives and whether it wants to lose weight or it doesn't want to lose weight. But by assuming that the surgery is working by forcing people to do something they didn't want to do, then what you're saying is surgery is a behavior modification tool. And surgery as a behavior modification tool will get you to the wrong answer, because that's not how surgery works. So we need to understand it well enough to know that that's not how it works. In addition, if we understand that surgery is changing physiology, surgery being like a drug, except a super powerful drug, makes it more acceptable to most patients, most of the public, and most physicians, because we're used to that. We're used to using drugs, or we're used to using lifestyle change to change the body's physiology. We do that all the time. If we're trying to lower blood pressure, we're using drugs. It's not magic when drugs lower blood pressure. They change the physiology. They change the tension in the arteries so that the blood pressure goes down. They loosen the arteries a little bit. If surgery works in that kind of a way to lower the set point for fat mass, then it allows it to be a more acceptable approach simply because it's a more natural approach than it would seem at first instance. So knowing enough about the mechanism to know that it's not quite so draconian, it's not quite so medieval as many of us used to think, I think improves the nature of the conversation. It allows the surgeon to talk to the referring physician and the patient with a little more understanding and a little more empathy. It allows the patient to have a better set of expectations about what surgery can do and what it can't do. Surgery is not a starting point for weight loss. Surgery is the mechanism of the weight loss. Just like when drugs are used, they're the mechanism. When a healthy diet is used, it's the mechanism. Surgery does not work by forcing you to eat fewer calories or burn more calories. Surgery works by changing the physiology so that your set point is lower and your brain wants to lose those calories. It wants to eat less. If surgery worked by forcing you to eat less or absorb less, you should become hungrier as your body tries to react to the surgery. The fact that virtually everybody after surgery becomes less hungry, it's telling you that it's working physiologically. Because again, almost everybody who gets an operation has already been on a diet. They will tell you that on a diet they're hungrier, just like President Taft did. But after surgery, they're going to tell you, no, I'm not as hungry as I was before. Food doesn't call out to me the way it did before. I don't crave things the way I did before. That's in the brain, and that is a physiological response.
Very thought-provoking indeed, and hopefully that gets people interested in going straight to week 3 of the Metabolic Applied Research Strategy massive open online course at ethicon.edx.org, where we talk through exactly how, or what we know about how surgery works. So with that, Dr. Kaplan, I'll leave you to the, I'll give you the last word. Is there anything else you'd like to get across to folks who are watching either live or will watch the archived version of this?
But I think what's important to recognize is that, as I said earlier, 20% of the human genome is devoted to managing energy and energy balance. And energy balance is what sits behind how much fat we have and whether or not we have obesity. There's a reason why we devote so much of our genome, so much of our physiology, so much of our biology to this process. But one of the effects is if you've got 5,000 genes collaborating to do this, it tells us that this is a complicated system. When it goes wrong, which it has in the modern environment, fixing it is really complicated work. And so the fact that it's not easy, and the fact that our understanding is incomplete, and the fact that we're not as successful as we want to be, doesn't mean we'll never be successful. It just means that we need to work harder and recognize that obesity and the biology underlying the causes of obesity is really very, very, very hard work and very, very hard to understand. So if it takes a while to understand it, or it doesn't seem intuitively obvious as we go through it the first or the second time, join the club. We're all struggling with this because it turns out to be, somebody once said, obesity is not rocket science, it's much harder.
I like that.
Very complex business.
Excellent. And on that note, Thank you once again, Dr. Kaplan, for joining us and for shedding light on, like what you said, is a very complex issue indeed. And I'll thank all the viewers as well for jumping in and tuning in on this Tuesday morning. So with that, we'll end our broadcast. And again, Dr. Kaplan, thanks so much.
My pleasure, and good luck to everybody as you work to help your patients if indeed you're providers.
Wonderful. Great note to end on. Take care, everyone. Bye-bye.